Good evening, everyone. Good evening, everyone. Today's my talk is about incidence and clinical outcomes following diffuse lamellar keratitis post-SMILE. So, DLK is characterized by inflammatory infiltrates in the corneal interface, and it usually presents within 24 hours after the refractive surgery. Patient typically presents with pain, foreign body sensation, photophobia, and blurring of vision. Even though it is most commonly seen after LASIK, it is also seen to develop post-SMILE. In different studies conducted by Fernando H. et al., for example, higher energy level was associated with increased risk of DLK post-LASIK. In another study, there was association of thinner lenticules and larger diameter lenticules with higher incidence of DLK, although the overall incidence of DLK was much low compared to LASIK in SMILE group. So DLK is a typical complication of LASIK, and previously the studies have discussed this complication post-LASIK. It is also a possibility with any lamellar surgery like SMILE being no exception to it. Although the exact pathophysiology is uncertain, there are some risk factors for DLK, which is like excessive surgical manipulation, higher energy level, repeated use of negative pressure suction, and other agents like meibomian gland secretions, air, dust, and bacteria. Lastly, also individual patient differences in sensitivity to lasers. So coming to grades of DLK, grade 1 is with peripheral infiltrates, not in the center, and grade 2 is when the infiltrates are migrating from periphery to center, and grade 3 is also known as threshold DLK, in which the permanent scarring will start to appear. Grade 4 is with stromal melting and scarring, and there is hyperopic shift. The aim of the study was to report the incidence management strategies, clinical outcomes following resolution in cases of DLK post-SMILE. This is a retrospective study from December 2021 to 2022, and the sample size was 1,313 eyes of 656 subjects. And we measured UDVA, CDVA, and OSI, intraoperative parameters and postoperative treatment, and the clinical outcomes. The mean age was 26.5 years, with the incidence 1.37%, 18 eyes of 15 patients had showed DLK. Minimum lenticule thickness was 82 microns. The mean time of presentation of DLK was 2.72 days, with a mean resolution time of 8.94 days. The parameters UDVA, CDVA, and OSI, when compared between the presentation of DLK and resolution of DLK, they all showed statistical significant values. And when compared the CDVA of resolution of DLK with the preoperative value, there was no statistical significant difference, showing that all the cases of DLK at the resolution, they were comparable to the preoperative CDVA values with no loss of visual acuity. The incidence was 1.37%, of which 11 were grade 1 DLK and 7 of them were grade 2 DLK. And all the grade 1 DLK cases were treated with topical steroid therapy with no sequelae and no adverse effects. And the remaining cases of grade 2 DLK were managed effectively by interface wash. This is the ASOCT of the grade 2 DLK, in which you can see the interfaces, there are infiltrates in the interface even involving the center. And this is the ASOCT of the same patient after the interface wash. So when we studied the correlation between OSI at presentation of DLK with age, energy, and lenticule thickness, there was no statistically significant values. So in conclusion, a large data set, although which is not desirable, it could give us a more precise estimate of the results, and the treatment would depend definitely on the stage that it presents. The earlier it is diagnosed and managed, patients showed better prognosis, and OSI can be a helpful parameter in the management of DLK. Hence, DLK post-SMILE, when recognized and managed early using an appropriate approach, results in satisfactory outcomes without any permanent effect on the visual acuity. Thank you.
So what was the post-op management given to most of your SMILE patients, and how did you change it for the patients who you felt presented with DLK?
We give Predfort, ma'am, 4 times a day for 1 week tapering, and tobramycin antibiotic drops for 1 week, and lubricant, gel, and drops. So the mean age of time of presentation was between 2 to 15 days. So whenever they presented, we stepped up the steroids to at least 5 times tapering dose, and we kept calling them for a frequent follow-up, and we kept measuring the ASOCT and the OSI for the follow-up visits.
That's not much of a step up from 4 times to 5 times.
Basically, if they are, we also checked the OSI, ma'am. If it is too high, we stepped it up to 6 times. So we kept that as a sort of parameter, and we kept calling them every 2-3 days for the regular follow-up. Depending on the OSI and the type of the, how much it is involving the center, depending on that, we have stepped up the steroids.
What was the main reason that you could find for DLK in your patients? What was the
Most of them had meibomian gland dysfunction, dryness. That was the main factor which we have seen.